on early pregnancy. This is not a course. Whatever we are taking, this is not a course but a CME. Complete course is available on our website and you can register for that. So the point is, this is not the course right now which we are about to start, but a small CME, you can say a workshop or a CME on early pregnancy scanning. Now, first of all, we will take theory. Small theory is very important when you are scanning. I will say not a little knowledge of this theory is important, but theory is the backbone of ultrasound. Merely doing ultrasound will land you nowhere unless and until you don't know the theory. What will you implement on the patient on the ultrasound? What you will implement? So, not knowing the theory and proper implementation of the theory is all of the ultrasound is what about. So, let's discuss the theory of early pregnancy first, and then I will show you slides. I will show you pictures of ultrasound, and lastly I will show you the live patient scanning of early pregnancy scanning, and at the end we will take the MCQs also. So try to be interactive. Those who are who have joined with us via Facebook and YouTube also are requested to comment in the comment box. Whenever I will ask any question or any point to discuss, you have to comment in the comment box. And those who have joined us via Zoom, there is a chat box or a comment box. It is a comment box over there also. When you will see there are three dots over there, that is the more option itself. You can see that there is a comment box also. Now, those who are joined with us via the Zoom, there is another option of raise hand. Whenever I say raise hand, don't raise this physical hand, but the raise hand pop-up which will appear in your Zoom, I mean the more dialog box of the Zoom application. So raise hand options will be applicable for Zoom registered candidates only, not applicable for Facebook and not applicable for the YouTube. But for YouTube and Facebook, you are having a comment box where you can comment over there. So let's get started with our session. So, starting the session. Early pregnancy ultrasound. So, a small intro of the embryology. Millions of sperms are coming to fertilize a single ova, but eventually only some 50 to 100 reach the ova, and ultimately, usually only one penetrates in. So here comes the human egg, which is in a pronucleate stage. This egg has enlarged but still is at a single cell prior to the first cleavage. Then comes the first cleavage, in which the egg is splitting in two. Then comes the second cleavage, where the egg is splitting in four. And then comes the third cleavage, where the egg is splitted into 16 cells. Now, this is a fertilized human egg, which is called as zygote, which has reached the blastocyst stage. Zygote contains fluid, and this is called as blastocyst and is preparing for implementation in the endometrial cavity. Now, this all is not in endometrial cavity yet. This is somewhere in the fallopian tube. This is very important to understand. This all is going in the fallopian tube. Now, here is the fallopian tube. Now, when I am talking of this fertilization occurs over here in the fallopian tube. Now, question. Whatever we will be discussing is very, very, very important. Whenever you will be holding the probe, you will come to know the importance of these things, what we will discuss. Now, from this end to the endometrial cavity, how many days a fertilized ova takes to drop in the endometrial cavity? Facebook, these YouTubers, whosoever is live with me on YouTube, please comment in the comment box. And Facebook also, whosoever has joined via Facebook, please comment in the comment box. And whosoever has joined via Zoom, comment in the respective chat boxes. I don't want it to be one-sided. So comment how many days a fertilized ova takes to drop into the endometrial cavity. It means that how many days now I am getting Dr. Chandan Bhushan 4 days, Dr. Sarita 5 days. Let me go to the chat box. 3 days. After 7 days, Dr. Chandan, Dr. Sonu 4 days, Dr. Coco Srideva 3 days, Dr. Sarita 5 days, Dr. Anusha 4 days, Dr. DP Gangwar 3 days, Dr. Elsa Chandi 7 days, Dr. Namrita 3 to 5 days, and the chat is going on, which is very good. Now the point is, it is not actually the 7 day. Whosoever is telling me 7 days, 6 to 7 days, no. It is roughly 3 to 4 days. These points are very, very important. So this is approx 3 to 4 days. It means that the fertilized ova is taking about 3 to 5 days to travel the whole length of the fallopian tube to drop into the endometrial cavity. Next. Okay, now it has dropped into the endometrial cavity. It has dropped into the endometrial cavity. Now, next question. Is it implanting the same day when it is dropping into the endometrial cavity? Is it dropping same day when it is dropping into the endometrial cavity? Or it takes time to get implanted? So first, we know now 3 to 4 days it is traveling from one end to another to drop into the endometrial cavity. Next question, is it the same day that it is implanting after dropping into the endometrial cavity, or it takes time? If it takes time, how much it takes to get implanted after dropping into the endometrial cavity? In your chat boxes now. Implantation, Dr. Reno 24 hours, Dr. Vanipuri 1 to 2 days, Dr. Anusha 3 days, Dr. Uma, 24 to 48 hours. Dr. Nipura, 4 to 5 days, and the chat is going on. And about 90% are saying me 24 to 48 hours. It means 1 to 2 days. Very good. So make a red note in your notebooks that first, how much time it is taking to drop into the endometrial cavity. I mean traveling of the in the fallopian tube, 3 to 4 days. Then it takes 1 to 2 days to get implanted. Now, see the importance of knowing these questions. Now, if this is 14th day, when the ovulation occurs, it is somehow 12 to 14 days. So let's take 14 days. 14th day ovulation, then it is traveling about 3 to 4 days. The fallopian tube keep on adding. 14 plus 4 is 18. Then 2 days it is searching for the site or getting implanted. Then 18, it means that it is getting implanted about a 20 to 24th day of the LMP. Your machine is calculating as per LMP. Machine is not knowing when the patient has ovulated. So machine is calculating as per LMP. So it means that I will be adding these 3 to 4 days and 2 days on to the 12 or 14 day. It means that this implantation is about a 22nd day of LMP. Now, this was a brief of embryology. We will come back to this embryology when we will be taking the ectopic pregnancy. Ectopic pregnancy is not in this virtual CME, but maybe that we will be announcing someday. These points are very, very important in the ectopic pregnancy. For example, if we are having a long tube, if we are having a tortoise tube, if we are having a narrow tube, it means that the 3 to 4 days will get stretched maybe up to 8 to 9 days. So there is the risk of ectopic pregnancy, which we will discuss. So this is the backbone of this embryology is itself a backbone. Yes, I am repeating, of early pregnancy scanning. Now, what is a pregnancy? A simple question: what is pregnancy? Is pregnancy a fertilized ova? Whosoever is thinking yes, keep your answer with you. Is pregnancy an implanted blastocyst? Whosoever is with this, keep your answer with you. I will come back to you. Now, what is a chemical pregnancy actually? Chemical pregnancy is the pregnancy when we are having detectable level of beta HCG. This is not clinical pregnancy. This is a chemical pregnancy. Chemical pregnancy is the pregnancy when we are having a detectable level of beta HCG. Now, what is a clinical pregnancy? A clinical pregnancy is when patient is aware of that she is pregnant. When she will get aware of? Whenever she will miss the period. So that is a clinical pregnancy. Now, what is a menstrual abortion? Give a thought. What is a menstrual abortion? Anybody having any idea of menstrual abortion? In your chat boxes or comment boxes now. This is very, very, very important to understand what is menstrual abortion. In your chat boxes now, hurry up. I am keeping an eye on the chat box. What is menstrual abortion? Unable to implant, failure to implant. Dr. Vanipuri is saying unable to implant. Dr. Anusha, failure to implant. This is not an appropriate answer. I want an appropriate answer. What is a menstrual abortion? Dr. Vanipuri is now writing, when there is chemical pregnancy but no implantation and patient bleeds on expected day of menses. Very, very good. Dr. Mirdula, Dr. Orvashi, Dr. Jyoti, Dr. Shruti are also commenting, but I will take the comment of Dr. Vanipuri, when there is chemical pregnancy but no implantation and patient bleeds on expected day of menses. This is about a 90% relevant answer. Now let us go back to the embryology. Now see the importance of embryology. I told you that that's the backbone. This is the backbone. Now we discussed that 12 to 14 day is the ovulation day. 14th day, okay? So 4 days it is traveling, 14 plus 4, 18. So 18th day it is dropping into the endometrial cavity. 2 days it is searching for the site. It means that it is about a 22nd day when it is about to implant. But what if, try to understand, what if it will not get implanted? It will get thrown out. Now, what will be the day? Try to understand. What will be the day when it will be thrown out? So that will be approx a 24th day, maybe 25th day. Now, whenever it is shed out, it is thrown out, patient is bleeding. Now, patient is not aware of that there is a blastocyst which has not got implanted. What patient will now think of? In your comment boxes now, what patient will now think of? She is not aware of that there is a blastocyst in her uterus. What patient will think of now? Yes, Dr. Jyoti, patient will think of patient bled a bit early. Now see, these are the comment boxes over here. Patient will think that early menses or on expected day. Dr. Vanipuri, Dr. Manish Tiwari also, Dr. Sarita also, and others also are thinking on the same line. It means that now we are understanding the things. I'm very happy for you. It means that patient will think that the menses have come some days early. But actually, she is not only menstruating, but she is throwing out the blastocyst. It means that we are dealing with the menstrual abortions. This thing. This is menstrual abortion. Is this very rare? No. This is not rare. Literature is saying about a 20 to 40%. Try to understand. About a 20 to 40% of implanted blastocysts are thrown out by these menstrual abortions. That is why I started with what is pregnancy. Now, whosoever is thinking that pregnancy is an implanted blastocyst, here is the answer. That about a 20 to 40% of blastocysts after even implantation are thrown out. Now, whosoever is thinking that no, I will come to the first option, that pregnancy is the fertilized ova, there is a shocking information that about a 40%, more than 40% of these fertilized ovas are thrown out. Now, question. Why? Why these implanted blastocysts or these fertilized ovas are thrown out? Why? Is this always due to the low receptivity of the uterine cavity or something else? Of course, the low receptivity is also a point, but majority of these blastocysts are thrown out due to some other reason. What is that? In your chat boxes now. Chromosomal abnormalities, Dr. Jyoti, yes. So this is because of the chromosomal abnormalities that they are thrown out. Now, if you have not seen a God, in this slide you can see the God, but you cannot see the God by your naked eyes. You have to imagine the power of Almighty God. Now, how? Now, if we will do maths, we will keep on adding these percents, how many percent of fertilizer ovas are thrown out, how many percent of implanted blastocysts are thrown out. We will come to the conclusion, which is not possible in a very small CMU or a workshop. These things we are discussing in great detail in our courses, but I will give you a rough estimate that about a 70 to 80% of chromosomal abnormal fetuses are thrown out. It means that only 20, now try to understand, it means that only 20 to 30% of fertilized ovas will land in a live baby. Now, what is normal? An English word, normal. What is normal? Normal is something which we are seeing routinely. That is normal. Now, normal is that I am having 2 eyes, 1 nose, 1 head, 10 fingers. Why this is normal? Because everybody is having these 10 or this 1 or these 2 eyes. Now, if all fertilized ovas will result in a live baby, what will happen? What will happen is that we will be flooded with chromosomal abnormalities. And chromosomal abnormalities are having a high possibility of having the structural deformities also. It means that about 80% will have some type of structural deformities. So, what is normal? 10 fingers. And then if we will land in every fertilized ova to have a live baby, then we will be having maybe 20 or maybe 18 or maybe 16 fingers as normal. Because what is normal? Normal is what we are seeing routinely. Then people will say, Dr. Vani is having only 1 nose, I am having 4. He is abnormal. Now, this is the power of God, that He is eliminating all chromosomal abnormal fetuses. Not all, about a 99.8%, if not 9% of chromosomal abnormalities, abnormal fetuses are thrown out. What we are seeing is about a half or maybe a 1% of fetuses only. So, now, this is the point. The point here is that we should have at least a basic idea of embryology whenever we are about to touch the ultrasound probe. Now, what is the aim of early pregnancy scanning? The aim is to determine the gestational sac. Where is the gestational sac? The aim is whether this is viable or not, and how many fetuses are there, whether this is 1 or multiple. And we have to see for the gestational age. Because the gestational age, whatever calculated as per CRL or this mean gestational sac, maintains its superiority throughout the pregnancy. It is more superior than the LMP. I mean, ADD calculated as per LMP is not more relevant, but this gestational age calculated as per the CRL and the gestational sac is more superior than the ADD calculated as per the LMP. Then we have to, I am repeating thrice, we have to scan the adnexa in each and every patient of early pregnancy. Now, number Now see, fetal number in multiple pregnancies, we are having confusion sometimes. When we are dealing with a second or a third trimester patient, we are having sometimes confusion regarding this chorionicity and amnioticity. But if we will see how many number here, I mean how many gestational sacs and how many fetal poles are there, that will decide the chorionicity and amnioticity in not more than 5 seconds. But when we are labeling, diagnosing the chorionicity in second or third trimester, it will take about 15 minutes and not always very clear. So number, why number? Because I want to have a clear understanding of whether there is dichorionic, diamniotic, monochorionic, monoamniotic. So whenever there is confusion in second, third trimester scan, I mean the multiple pregnancy, go back to the early pregnancy scan. That is why I have written here fetal number. So this is the backbone. This simple looking slide is the backbone of early pregnancy scan. If you will not understand this, or if you are not able to interpret it, please don't touch the probe. I am repeating, please don't touch the probe. If you are having a clear understanding of this thing, then you can do wonders with the early pregnancy scan. Now, what is this? This is the uterine cavity. This is uterine cavity. This all is uterine cavity. Oh, sorry. This all is uterine cavity, and over here, is the amnion. I mean the gestational sac. This is gestational sac, and this is the uterine cavity. In this gestational sac, we are having one more thing, and that is the amniotic cavity. In amniotic cavity, now try to understand, in amniotic cavity, the king is itself. I mean the fetus is in amniotic cavity. But, so first of all, let's clear the things first. This is the uterine cavity. In this uterine cavity, I am having a gestational sac. This gestational sac is divided in two. One is extra and another is intra-amniotic cavity. The yolk sac is in extra-amniotic cavity, whereas the fetal pole is inside the amniotic cavity. Both are connected by the vitelline duct, but both are not in the same cavity. Next point. Very important. Next point, very, very, very important. If for the sake of argument, try to understand, whatever you are doing, having your tea, having your coffee, doing anything, leave that. For 2 minutes, leave that. And try to focus over here, try to concentrate over here. If this if this endometrial cavity, for the sake of argument, is 10 cc, for the sake of argument, if the endometrial cavity is 10 cc. Now question, is an early pregnancy gestational sac, I am using word early, is early pregnancy gestational sac always 10 cc or less? In your comment boxes now. Shreya, keep an eye on the comment sections. Less. I got about more than 100 candidates are with less, commenting from different platforms, YouTube, Facebook, Zoom. Everybody is saying less. Very, very good. Now, come back. If it is 10 cc, it will never be 10 cc. I mean, very early pregnancy gestational sac will never be 10 cc, it will be less. It will be maybe 5, maybe 4. Now, the point. What is coming out is that there will be unobliterated uterine cavity. So, this will be unobliterated uterine cavity. So, this is the point. So, in very early pregnancy, we will be having an unobliterated uterine cavity. How that is looking on ultrasound, that is my job. I will show you. First, clear the funda. Now the point is, if there is an ectopic pregnancy, in ectopic pregnancy about 30, if not 40%, we are having a pseudo-gestational sac. Will pseudo-gestational sac have an unobliterated uterine cavity? Never ever, because that is a fluid that will spread up in whole of the endometrial cavity. So come back to this normal pregnancy, we will be having an unobliterated uterine cavity. So the unobliterated uterine cavity is telling me that the sac is not an ectopic sac. I mean the pseudo-gestational sac. Now, question. I am having a bundle of questions for you, because questions will make you understand. Questions will make you understand. Now, as pregnancy is advancing, this gestational sac will increase. So, if we have decided to take, for the sake of argument, this endometrial cavity as 10, now when the gestational sac is growing, will it take whole of the endometrial cavity? Will there be any unobliterated uterine cavity when it is increasing? No. And there will be a confusion at about 8, maybe 7 weeks, with a small left behind unobliterated uterine cavity that will look like a hemorrhage. We will discuss each and everything, but first try to understand that there is this unobliterated uterine cavity also. So take a snapshot, take a photo, and paste this not on your wall but in your mind whenever you are doing ultrasound, early pregnancy ultrasound. Now, on ultrasound, I will be seeing a small gestational sac with decidual reactions. Now, whatever we have discussed is the unobliterated uterine cavity. Here is the unobliterated uterine cavity. Now this is the gestational sac. This whole is the endometrial cavity, and this is the unobliterated uterine cavity. Now, there is another thing which is called as double decidual site. Now, what is a double decidual site? Before double decidual site, this is again the unobliterated uterine cavity, which is looking like this on ultrasound, and this is the gestational sac. And this gestational sac will increase, and it will take the whole of the uterine cavity. But the point is, in very early pregnancy, I will be having this unobliterated uterine cavity. So, as pregnancy will advance, as the gestational sac will increase in the size, I will be having less of unobliterated uterine cavity. Then I will be having this much of unobliterated uterine cavity only. Now tell me honestly, if I will not be knowing, I am not knowing that there is something which is called as unobliterated uterine cavity, and you are putting the probe over here, what you will label this area as? Tell me very, very honestly in your chat boxes. If you are not knowing that there is something which is called as unobliterated uterine cavity, what you will label this area as in your chat boxes now? Tell me honestly. Hemorrhage, hematoma. There is shadow, please correct. Hemorrhage. Now see these comments. So this is the importance of knowing the things. Now, question. Now I know that there is something which is called as unobliterated uterine cavity. Why this cannot be a hemorrhage also? Question: how to differentiate a hematoma from this small unobliterated uterine cavity? Question. I am repeating the question. I am having two possibilities over here. One is the left behind unobliterated uterine cavity or the hematoma. How to differentiate? Clinical features, Dr. Vanipuri, Orvashi Selvam, clinical features, color flow, Dr. Nirupama, sliding sign, no. Hemorrhage within the sac, Dr. Harjinder Kaur, everybody has to comment. Facebooks, whosoever has joined via Facebook also, YouTube also, and Zoom also. Rescan after 1 to 2 days. If it decreases in size, then it can be unobliterated uterine cavity. This is the comment from Dr. Meridula. Very, very good. Others are going with color Doppler and whatever they are posting now. See yourself, beta SEG and all these things. No. Rescan the patient after 2 days and recall the backbone. What is the backbone? Is that slide. Now see, if I will go back to that slide here. If this is a gestational sac. If this will grow, whenever it will grow, it will take more of the cavity. It means that the left behind unobliterated uterine cavity will decrease. If that is a true unobliterated uterine cavity, and clinically also, if patient is not bleeding, now you have to put all the things in one basket. One picture is not telling you anything, and not any picture will tell you anything unless and until you are having a small, strong fundamental clear. I mean the theory. If you are having clear, then only you can do wonders with ultrasound. Otherwise, you will turn into photographers only. So the point is, if patient is bleeding, then I will think all lines of hematoma. And if patient is not bleeding, I will put question to myself. Can it be an unobliterated uterine cavity? And then I will rescan. And on rescanning, if this is increasing, then that goes against unobliterated uterine cavity, because if it is unobliterated uterine cavity, it has to decrease. And if it is decreasing, then it goes in favor of unobliterated uterine cavity. And if it is increasing, then it goes against. So this way you have to put multiple things in one basket, then only you can make a diagnosis. Otherwise, these pictures, these high-end machines are complete waste for you. So now, let me put you a question before taking a short break. What is a double decidual sign? What is a double decidual sign? Now, please don't comment. See to this, whatever is reflected over here. The double decidual sign is the makeup between, let me minimize this. Double decidual sign is the makeup of the decidua parietalis, that is the lining of the uterine cavity, and the double decidua capsularis, that is the lining of the so whosoever will comment this only in one way or another, but the point is that you will be saying this only. But are you knowing whatever you are stating? I am telling you with a confidence of about 90%, no. You are not understanding what you are uttering. You may get 10 out of 10 in your exam, but actually you don't know what you are stating. Now, let's try to simplify this unobliterated uterine cavity. There are two deciduas. One is which is coming from the uterine cavity over here, and another is which is coming from the gestational sac. So there are two deciduas. Okay, let it be. Now the point is, if there is an unobliterated uterine cavity, then only I can see two distinct deciduas. Try to understand. if I am having an unobliterated uterine cavity, then only I can see this decidua and this decidua. Why? Because if there is no unobliterated uterine cavity, both will come together and merge with each other. It will look like one only. What it means? It means that whenever shake your head and whatever you are doing, leave that for 10 minutes and concentrate over here. It means that double decidual sign is nothing but the reflection of unobliterated uterine cavity. In other words, whenever there is unobliterated uterine cavity, that DDS has to be positive. So, whenever you see an unobliterated uterine cavity, then only you can see two distinct deciduas. So, in one line, the double decidual sign is nothing but the reflection of unobliterated uterine cavity, or unobliterated or DDS cannot be seen without unobliterated uterine cavity. At the point. So over here, this is one decidua and this is another decidua. Imagine that if there is no unobliterated uterine cavity, can you see this and this separately? No. So DDS has to be positive if there is unobliterated uterine cavity. Okay. So without break, we are running short of time because we are having only 15 minutes for today's session. We'll be continuing tomorrow. Without any break. What is an abnormal gestational sac? Abnormal gestational sac is if we are having an abnormal size, distorted shape, or if we are having a thin ecogenic trophoblastic invasion, that is the weak trophoblastic decidual reactions, or a low-lying gestational sac. Now, there is another thing which is called as oligoamniotic sac. An oligoamniotic sac is that sac, try to understand. Oligoamniotic sac is that sac in which I am having less of fluid. But how much less? There should be a scale. How much less? Now, try to understand first. If I am putting a probe, whenever I am putting a probe, I am measuring two things. In early pregnancy, I am measuring the CRL and the mean sac diameter. How to measure that? That is the part and parcel of our course. Right now we are taking a workshop only. We are showing you there how to measure that, how to measure this. So not possible in a virtual CME of 2 days. Actually, this early pregnancy ultrasound is about how much duration? And so
45 days.
45 days. So 45 days by our server. So now, whenever you are putting probe onto the patient, you are measuring two things. One is CRL and another is the gestational sac. Now, for example, we are having a 9 weeks. As per LMP, it should be 9 weeks. Whenever I am putting probe, CRL is plus minus 1 week, 9 weeks. But the gestational sac itself is not 9 weeks, it is 5 weeks. Then I will knock on my head. Can it be an oligoamniotic sac? And then only I will measure the both. Now, time and again, I am telling you, why should I open the door if nobody will knock on my door? If anybody will knock my door, then only I will get onto my foot and I will go there and I will open the door. Why unnecessary? I will open the door all times. So this is the knocking factor on your head whenever there is a discrepancy between the gestational sac and the CRL measurements. Then how much should be there? Now the oligoamniotic sac mean sac diameter minus CRL should be less than or equal to 4 millimeters. That is oligoamniotic sac. Now if this CRL is 12 millimeters and the mean sac diameter is 15 only, I will extract how much? I will subtract 12, from 15, that is 3, so that will be oligoamniotic sac. Now, oligoamniotic sac, let it be. Why I am spending so much of energy in understanding this oligoamniotic sac? No, I have to. Why? Because there had been a study conducted by Brawley in which 16 patients, try to understand, 16 patients between 6 to 9 weeks with oligoamniotic sacs had 15 abortions. 15 out of 16. It means about 90, if not more, percent of oligoamniotic sacs are lost. Now, if a patient is in India and I am scanning and diagnosing an oligoamniotic sac, I will not allow her to go to US because she can bleed somewhere in air. So this is the importance of knowing oligoamniotic sac. Now, if you don't know that there is something called as oligoamniotic sac, you are seeing only CRL, a beating fetal heart, everything will be apparently normal over there. You will label that as normal, and next day patient will come with bleeding PV, and patient will ask you, yesterday I was normal, or a day before yesterday everything was normal. Then patient will maybe shout on you. But if you will label that as oligoamniotic sac, there are high chances of losing that fetus. So this is the importance of knowing the oligoamniotic sacs. Okay. Tomorrow we will discuss the yolk sac and the this yolk sac detachment. There are many more things of early pregnancy which we have to discuss tomorrow. Now I will give you some questions. Let us see. Let us see how many of you will hit that right. So we will go to questions now. Patients we will show you tomorrow. मेरा कैमरा देख लें. So getting up. Now you have to comment in your comment boxes. Now you know why is your comment box. Question number 1. Fertilization typically occurs within dash dash after ovulation. 40, 12, 24, 56 hours. Your time starts now. 10, 9, 8. Comment in your comment boxes. 7, 6, 5, 4, 3, 2, 1. Dr. Uma 24 hours, Dr. Komal 24 hours, 24, Dr. Nirupa, Dr. Rupesh 24 hours, 24 hours, Dr. Leena, Dr. Babra and others 24, but somebody is telling me 40, no, it is 24 hours. 24 hours only. Now next question. The most common site of fertilization is within the A, B, C, D. What is A? Isthmus of the uterine cavity, uterine fundus, corner of the uterine tube, ampulla of the uterine tube. Time starts now. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Time up. Ampulla, Dr. Komal, Dr. Rupesh Urvasi, ampulla, Dr. Leena, ampulla, Dr. Elsa, ampulla, Dr. Ankitu, ampulla, Dr. Deepak, ampulla, Dr. Mehna, ampulla, Dr. Uma, ampulla. Very good. It is ampulla, that is D. Now the structure created by the union of the sperm and egg is, I will not give 10 seconds, only 5 seconds. A, B, C, D, blastocyst, zygote, morula or ampulla. For 3. For 3. Yes, it is B. Dr. Vanipuri, Dr. Chandra, Dr. Urvashi, Dr. Harbinder, Dr. Koko, Dr. Ritu and Dr. Elsa, Nishu and others. Very good. Fourth, 5 seconds only. The trophoblastic cells produce A, B, C, D. Yes, everybody, Dr. Neha, Dr. Aarti, Dr. Elsa, Dr. Anusha, Dr. Priya, Beta SEG, very, very good. Next question, fifth. What is the stage of the concept that implants in the deciduous endometrium? Is this blastocyst, marula, zygote, or ova? Fifth. 5 seconds only. Fifth. Blastocyst, marula, zygote, or ova? Blastocyst, 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 everybody, Dr. Mutib, Dr. Anku, Dr. Aarti, and others are posting me the blastocyst. Very good. What structure lies next to embryonic xylem? Is that gestational sac, embryo, yolk sac, or amnion? Question number 6. Hurry up. Yes, that is C, yolk sac. Very good. Dr. Urvashi, Dr. Mirudula, Dr. Leena has hit it right. Seventh, which hormone produced by the corpus luteum maintains the thickness? Very easy question. Estrogen, progesterone, HCG, or luteinizing hormone? Hurry up, hurry up, hurry up. Progesterone, yes. In next question, 8. In the first trimester, normal HCG levels will double every 48 hours, triple every 24 hours, double every 24 hours, double every 12 hours. So is this A, B, C, or D? Read it yourself. 8th. Dr. Ritu, Dr. Urvashi, Dr. Komal, Dr. Chandra, Dr. Rupesh, Dr. Nisha doubles every 48 hours. Very good. So that is A, doubles every 48 hours. Now compared with normal IUP, intrauterine pregnancy, the ectopic pregnancy will have a high beta HCG, low beta HCG, markedly elevated HCG, or high AFP. Question number 9. Hurry up. A, B, C, D. Dr. Manish, Dr. Coco, Dr. Anusha, low, Dr. Uma, low, Dr. Mahbuba, low, Dr. Chandra, low, Dr. Sarita, low. Everybody, I am very happy you are getting it right. So that is low beta HCG. Question number 10. The first sonographic identifiable sign of pregnancy is that. Try to understand the question first. The first sonographically identifiable sign of pregnancy is the amnion, yolk sac, residual reactions, or chorionic cavity. For 10th, it is A, B, C, or D. Try to understand the question first. The first sonographically detectable sign of pregnancy is there. I am not saying any viable, non-viable. I am just saying the first sonographically identifiable sign of pregnancy is the amnion, yolk sac, residual reactions, or chorionic cavity. For 10th. I am expecting 50% to hit it right, because this is a tricky question. Now somebody is posting me chorionic cavity. No. Dr. Chandra. No. Dr. Vanipuri. Residual reactions. Very good. Dr. Rupesh. Not the yolk sac. I told you the first sonographically identifiable sign of pregnancy is not the yolk sac identifiable. It will be the residual reaction. 11th, the first detective sonographic sign of an intrauterine pregnancy is the recognition of. Now try to understand the question first. The first detective sonographic sign of an intrauterine pregnancy is the recognition of yolk sac, embryo, decidual reactions, gestational sac. So now try to understand. This is intrauterine pregnancy written over here. Gestational sac, 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 and everybody is posting gestational sac. I will not name now. Very good. Last question for today. The normal gestational sac will grow. How much? First, try to understand how much the normal gestational sac is growing per day. These are very important points. This only will decide whether this is a normal or abnormal gestational sac. Sorry. 12. The normal gestational sac will grow 2 millimeters per day, 3 millimeters per day, 1 centimeter per day, 1 millimeter per day. For 12. Last question for today. Everybody has to comment. This is last question, and with this we will conclude. Mixed response, mixed response, mixed response. Somebody is posting 0.7. Why is 0.7 mentioned? Dr. Nirupa, why is 0.7 mentioned over here? Dr. Priyanka, 1 to 2 millimeters. No, I don't want 1 to 2 millimeters. I want it either 1 or 2. What is most appropriate? Dr. Aarti, 1. No. Dr. Anusha, 2. Yes. Dr. Priya, 2. Yes. Dr. Kailash, Dr. Urvashi 2, Dr. Chandra 2, Dr. Mirudula 1, it is not 1, it is 2, Dr. Coco 2, Dr. Mahbuba 1, it is not 1, it is 2, and others. I am getting a mixed response of about 70% are posted 2 millimeters, so make a red note that it is 2 millimeters, not 1 millimeter. Okay, so we will be continuing tomorrow. We'll be continuing the session. If anybody is having any question, whatever we have discussed today, they can raise the hand. And those who are live with me via Facebook or the YouTube, you can post in the comment box your questions, if any. We are continuing the session tomorrow also. So if anybody is having any question, whosoever has joined on Zoom can raise the hand, not this physical hand. There is a more option, 3 dots are over there. You have to click over there and the raise hand option will pop up. Then what we will do, we will unmute your mic from our side and we will get live with you. Hurry up. So please hurry up. If anybody is having any question, they can raise your hand, their hands on Zoom only, not on Facebook and YouTube. This is applicable for Zoom only. And if you are with me on Facebook, you have to post your question in comment section. Keep an eye on the comment section. Hurry up. Dr. Chandra is raising the hand. I am unmuting. Please accept the unmute invitation and on unmuting say hello. Hurry up. Yes, hello. Okay. Anything else? Now, the point is, what is a double decidual site? The doctor wants me to elaborate it. There are actually 2 deciduals. Try to understand. There are actually 2 deciduals. One is which is coming from the gestational sac and another is which is coming from the endometrial cavity. So if this hole is endometrial cavity, one decidua will be from the endometrial cavity and another will be from the gestational sac itself. One is decidua capsularis and one is decidua parietalis. That is double decidual sign. But what we have discussed is that not the double decidual sign, but the unobliterated uterine cavity. Where is unobliterated uterine cavity? Unobliterated uterine cavity is in between the two. So I told you, if there is unobliterated uterine cavity, then only you can see two deciduas. Otherwise, both will merge with each other and it will look like one. Now, why this is important? The question is why this is important. That is the question which doctor has posed to me, Dr. Chandra. Because if I don't see two distinct deciduas, then there are high chances that I am not dealing with an early pregnancy. I mean the intrauterine early pregnancy. There are high chances that I am dealing with an ectopic pregnancy. Because in pseudo-gestational sac, there will not be double decidual sign because there will not be any unobliterated uterine cavity. So in differentiating the decidual, the pseudo-gestational sac from a true intrauterine gestational sac, I have to take help from this unobliterated uterine cavity in inverted comma double decidual sign. Anything else? Dr. Manish Tiwari, use of TBS in early pregnancy. Now, I told you in start that this is not the course right now which we are taking. Now, he wants me to discuss the TBS in early pregnancy, which is not possible in a CME. We are taking the basics of early pregnancy in this workshop. If you have any question regarding what we have discussed today, so please post your questions from the topic which we have discussed, or if you don't have anything clear from what we have discussed, I cannot take the whole of the early pregnancy course because this is about how much, 45, 30?
45, 60.
45 to 60 days course on our server. So you have to contact our helpline number for all details of our courses. If you have any question regarding what we have discussed today, you are more than welcome. Dr. Anusha, last question I will take. I will send you unmute invitation. You please accept it, and on accepting say hello, Dr. Anusha. Doctor, yeah, hello. Okay, the question is that I'm muting you because there will be a lot of background noise if I will keep everybody unmuted. The question is how to differentiate whether it is today's blood. I am simplifying the question. Whether it is today's blood or weeks ago, it means that whether it has bled today or some days before. We have not yet touched the hemorrhage. We will touch the hemorrhage tomorrow only, but for now, I will tell you, if this is a fresh blood, fresh means that it is just today or some hours before it has bled there, it means that I am dealing with the fresh blood. Now coming to the echogenicity, the question is what will be the echogenicity, how I can differentiate whether this is fresh blood or old blood. Older the blood, more it will get clotted, and in a clot I will be having more of echogenicity. So if I am having less of echogenicity, then I am dealing with the fresh blood, and if I am having more of echogenicity, then I am dealing with the clotted blood. But the point is, when the clot will resolve, then the echogenicity will drop. So echogenicity will decide whether this is fresh blood or old blood. Okay, see you tomorrow. Same timing. We will send you a link in your groups, and those who have joined us via Facebook and YouTube, we will be live same time tomorrow. Means it will be as per Indian Standard Time, it will be 6 p.m. onwards. Thank you very much. God bless all of you. See you tomorrow.